The broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to this RCPCH webinar on stroke in childhood, implications for paediatric brain attack and rehabilitation of childhood ABI. Thank you very much for joining us this morning. Today's presentation will be given by Dr Vijeya Ganesan, who's Senior Lecturer in Paediatric Neurology at UCL and at Ormond Street Institute of Child Health in London. We'll be having a presentation initially, which will take about 30 to 40 minutes, and then we'll be opening up the session for question and answers. Those of you who are listening to the webinar, you can submit questions to us through your webinar questions portal at any time, and we'll take them when we finish the presentation session. If you do experience any difficulties in connection during the webinar, you may wish to sign off and sign back on again, or you may wish to access the webinar through a mobile device if you're accessing it through a laptop or desktop computer in a trust. But if you are unable to hear at any point during the webinar and you can't reconnect, the webinar is recorded and you'll be able to access it within about a week's time on the RCPCH Compass Learning Management System. So for now, thank you very much for joining us, and I'll pass over to Dr Ganesan to start the presentation.
Thank you very much, Sarah. So Sarah said I'm a pediatric neurologist and I was chair of the RCPCH Stroke Guidelines Development Group. And the way I'm going to structure the presentation today is that firstly I'm going to give you some background to the guideline development, which hopefully will help you to understand the basis on which the recommendations were made. And then in the first bit of the talk, I'm going to focus on recommendations around acute care of children affected by stroke that I think will actually have implications for children with acute neurological presentations. And then in the second part of the talk, I'm going to speak on behalf of Anne Gordon, who chaired the rehabilitation section of the guideline, to pick out some of the recommendations relating to that. And I think that the rehabilitation aspect is really important because many of the topics that are covered are really generalizable to all acquired brain injury. That's what ABI stands for on the title slide. So for those of you who are not aware, the guideline can be accessed freely on the RCPCH website. And the background to this document is that in 2004, the Royal College of Physicians drew up guidelines for stroke in adults. And we were invited to contribute a guideline on childhood stroke that was developed under the sort of RCP umbrella. There was an expert group, many recommendations were made, but the guideline had a very poor uptake, really because it was not seen as being owned by the pediatric community. And so really pushed by the Stroke Association, so the charity sector, the feeling was that any revision or subsequent iteration should really be very much owned by pediatricians. And so with funding from the Stroke Association, the RCPCH took on developing a guideline that was eventually published in 2017. And as those of you who are members of the college will know, the RCPCH has a very rigorous guideline development process and an expert team who supported the work. And we convened a panel of stakeholders, over 30 experts in their respective fields. We set out at the beginning, because we were aware that the evidence base in this area was quite small, to plan to undertake a Delphi consensus process for questions that we thought would inevitably arise, but which we felt were especially contentious. I'll maybe cover one of those in a moment. The document is endorsed by NICE and over 20 professional bodies, and it covers the pathway from of a child affected by stroke from the pre-hospital phase right through to long-term care, rehabilitation, and transition to adult care. Uniquely in this document, the scope was increased to include brain hemorrhage, and this was really following input from parents who felt that this was an important omission in the previous document. And I think a really key part of this work was that parents in the charitable sector were embedded really from the beginning in the development process in a very meaningful and engaged way. So this is just a slide showing the organizations that have endorsed the document, which range from quite generic organizations like London Ambulance Service to quite specialist organizations such as the British Paediatric Neurology Association. I think it's important to talk about the role of parents. I think as pediatricians, we're aware of the importance of engaging parents and families, and parents really played a key role in the development of this document. So they very much lobbied the Stroke Association and members of Parliament to promote a revision of the 2004 document. And this led to a debate in the House of Lords, which lent a lot of political support for this. And several parents were recruited as active members of the Working Party. Not only did they inform the scope and a parent version of the document, which is available, I'll allude to that at the end, but they also participated as members of the guideline development group. So they reviewed papers, they generated recommendations, and they signed off just as any other GDG member. And they took part in workshops to develop consensus statements about some of the longer-term care aspects for which there was not much information, specifically around communication between professionals and families, the information needs and transition from pediatric to adult care. And then finally, as I said, there was a parent version of the document, which I would encourage you to pass on to families. So this is the pathway covered by this guideline, which really ranges from the very initial presentation and the referral pathway acute management, and then it splits into two sections pertaining to arterial ischemic stroke and brain hemorrhage, and then they come together again to consider discharge and longer term care. And in the presentation today, I'm really only going to talk about arterial ischemic stroke. I should say that the age range covered by this document is more than 28 days, so it doesn't cover neonatal stroke. And the reason I'm focusing on arterial ischemic stroke is because a lot of the recommendations around brain hemorrhage will really be more relevant to neurosurgical and intensivist colleagues rather than pediatricians. And I'm assuming most of the people logged in today will be from pediatric background. So the recommendations for acute care really relate to recognition and diagnosis, pathways for transfer of both the patient and imaging. I will talk a bit about hyperacute treatment. This is what everyone asks about, but also other emergency treatments that should be considered. And then finally, I'll just say a bit about the recommended model for management of cerebrovascular cases in children, which is that of a regional multidisciplinary model. So many of you will have seen the campaigns, the FAST campaign, Face, Arms, Speech, Time to Call, which is really the public-facing face of that stroke in adults is an emergency. This is obviously a sea change in the attitude towards stroke, and really this was on the back of the availability of hyperacute treatment. So the need to recognize stroke very quickly and get the patient to a treatment center within a 4-hour window, and this totally transformed care of adults with stroke. So in fact, the Guideline Development Group and Stroke Association have been campaigning to try and include children in this campaign, because actually most children who develop a stroke, so I'm using the term stroke here to cover both ischemic stroke and brain hemorrhage, so most children with a stroke will actually be FAST positive, so they will have an acute lateralized weakness. So these sort of outtakes from this sort of poster here on the right. This poster is, I believe, available on the RCPCH website. If anyone wants to download it, you might find it useful to put up in your department. But the boxes sort of cover different aspects of the pathway. And the first is really about identification. So as I said, acute focal deficit, speech disturbance, but I think it is important to recognize that many children with stroke will have so-called diffuse or non-specific signs. And particularly in younger infants, a depressed conscious level may be a feature of a stroke. And then I think the other important difference between adults and children is that There may be some rather less specific features that may indicate childhood stroke. So new onset focal seizures, we debated a lot about this. I think this is quite contentious, but it was just to highlight that a stroke, particularly in infants, can present with focal seizures, new onset and focal. New onset severe headache, so there we were particularly trying to cover brain hemorrhage, and particularly subarachnoid hemorrhage that can present with severe headache. Ataxia, dizziness, which may be indicative of posterior circulation ischemia, and then in contrast to adults where terms such as TIA and stroke are very rigidly time defined, in children the definition of stroke is really based on imaging, because many children with a relatively transient deficit will actually have brain injury on a scan. So I think the term TIA is maybe not such a useful term in children, and in my own practice I don't tend to use the term unless I know that the child already has a predisposition to have a cerebrovascular event. And then I think something that cannot be emphasized enough is that any neurology in a child with sickle cell disease should be considered stroke until proven otherwise, and it's an emergency in these children. So we made some recommendations about pre-hospital care, which I won't really go through since these are pretty generic, but I think there are a couple of things that I want to point out. First is the recommendation to ambulance crews is to use FAST criteria to assess children as they would adults, that children should be taken to the nearest pediatric unit rather than to a specialist stroke unit, as would be the case in an adult who is suspected of having a stroke. And then really that we would be encouraging local teams to define a acute stroke pathway, and that is something we're hoping that people will draw up in their own hospital, as to how they would respond to a call from an ambulance crew that a child was coming in who may have had a stroke. And the composition of who might attend in A&E will vary from center to center. Definitely a pediatrician, possibly an anesthetist, possibly an adult stroke physician. But it is something that perhaps we're hoping that events like this will prompt people to think about what they would do if they were going to get that call, how they would put a team together to manage the patient. And I should say that obviously at the point you get the call, it's a query stroke, but the child may have any variety of other acute neurological diagnoses. And I guess I would see one of the big implications of this guideline as really upscaling acute focal neurological deficits in children to the status of an emergency, which I think they are. The other differentials are things, many of which are treatable, like brain infection, and many of which will require specific interventions. And then the other sort of aspect that I should just flag up is really to involve a hematologist very early on if the child is known to have sickle cell disease, because the likelihood is you're going to move on to exchange the child very quickly, possibly even before you've done a brain scan. So this is really the point that's being made here about the sickle cell disease. And then here there are some just basic recommendations about the acute care, about supporting consciousness, oxygenation, fluids, etc., which I won't go over. So the recommendation of the guideline development group was that all children who have been shown to have a stroke should be transferred to a regional neuroscience center. And we recognize, I mean, all of us on the group are clinicians who are practicing, day to day, and we all recognize the challenges here. But the model that we sort of envisaged was really using local retrieval or intensive care teams to try and coordinate the acute management and to coordinate transfer. So we're not proposing that these children are taken to the regional centre by retrieval teams, but rather that the intensive care teams, we're used to conferencing many professionals in discussion about complex cases, that resource is used to maybe facilitate discussion between the DGH, the specialists in the tertiary centre, the radiologist, and whoever else you might want to involve. Now, having been involved in discussions in my own region, I recognize that this is something that is going to be quite challenging. And actually, you know, we have been trying to sort of move forward for some months. And I suspect that the way this is going to roll out is that until it all comes to a head in individual centers, it is going to be very difficult to thrash out an optimal pathway. And I think it's not going to be a sort of one-size-fits-all solution. I suspect that different regions will find different ways of making this work. Sorry. So I'm going to. Have we missed one? Sorry, I think we've slightly skipped, but I'm just going to skip ahead. It's fine. I'm sure we'll cope. So really, the reason for the whole issue about time critical transfer is the issue of hyperacute treatment. And just to give you some background, there was a trial funded by the NIH called TIPS, Thrombolysis in Pediatric Stroke. And essentially this collapsed due to non-recruitment. And essentially I think this means that there will not now be a pediatric hyperacute treatment trial. And the main reason this trial collapsed was because, as we all know, there are often diagnostic delays in diagnosing childhood stroke. There's a high rate of contraindications that I'll come to in a minute, and that there's a very high rate of stroke mimics. So by mimics, I mean conditions that look clinically like a stroke, but are actually something else like acute inflammatory demyelination, brain infection, etc. So in our guideline, we use the criteria used for this trial as the criteria that could be used to consider a patient for hyperacute intravenous thrombolysis, because we felt that these criteria had been ethically reviewed. And this was one of the recommendations that was put out to Delphi process. So some of you may have participated in the consensus exercise. This was a freely open process. So any stakeholder had the opportunity to comment. And then there were several iterations until we got a high level of agreement. And we also aimed to harmonize this with the Royal College of Physicians. Am I coming through okay? Royal College of Physicians guideline. So just to move on to what the recommendations are in terms of thrombolysis. So this is it really in a nutshell, what I'm pointing to. So essentially the wording is that hyperacute thrombolysis may be considered in children between the age of 2 and 8 and could be considered in children more than 8. So that the wording, it may not be clear, but this is the could is actually a stronger level of recommendation than the may. So there's a bit more wriggle room in the 2 to 8 years old, but it's maybe a bit stronger in the over 8s. And then these are the criteria that need to be fulfilled. So the child has to have a bad enough stroke. So this PED-NIHSS is a stroke severity scale, and the elements of it are pulled out here on the left. So this is essentially a scored neurological examination. And you know, this is one of the things that I think as pediatricians we need to just skill ourselves up in just running through this. You can download this off the RCPCH website on your phone and just run through it. And so basically the child has to have a severe enough deficit. The treatment, the TPA, needs to be administered within 4.5 hours of onset. So basically that means the treatment will need to start in a DGH setting. And this is something that is going to be quite challenging, how a specialist in a tertiary center and a general pediatrician in a secondary center work together in terms of administering this treatment. There are many exclusions I'll go through in a minute. But what major exclusion is to have excluded intracranial hemorrhage, that the CT shows minimal ischemic change. So if there's a big stroke, probably the risk of bleeding is too high, so more than 1/3 MCA territory. And in contrast to adults, we also require the CT angiogram to show occlusive disease of a major intracranial artery. So this is a big difference from adults, where the appearance of the brain vasculature doesn't determine the criteria for thrombolysis. And so there are CT criteria and there are MR criteria. And then the other main important thing is that providing there are no contraindications. So in fact, I mean, my gut feeling, I don't work in a hospital with a A&E, but my gut feeling is that the average DGH is unlikely to see even one patient meeting these criteria per year. So this is a low frequency, but obviously a highly complex management pathway. And actually what I am going to, I'm just going to whiz back. I hope it's not too disorientating, but I'm not going to go through these, but you will see when you go through the slides in the webinar that we have listed the contraindications, and I just put these two slides up here to show you that there are a heck of a lot of contraindications. So I would say, I mean, this is why the trial collapsed really, because none of the patients had no contraindications. As you know, many children with stroke will have many medical comorbidities that will preclude treatment. So I think it's definitely worth also having the list of contraindications, because if even if the child meets all the other criteria, you may well find that they are not eligible because of one of these reasons. So just to move on a minute to imaging, the recommendation is that any child who has acute focal deficit should have a brain scan within an hour of arrival in hospital. And, you know, we recognize that that is challenging, but that's the standard of care in adults. And we felt that really without being aspirational, that, you know, system was not going to change. And obviously MRI has better spatial resolution, doesn't involve ionizing radiation, but, you know, in the real world it is unlikely that a sick child will be able to get an MRI within an hour. And, you know, remember the time window overall is 4.5 hours from onset. So the recommendation is if MRI is not possible, there should CT and a CT angiogram should be undertaken. Now the CT angiogram is an examination that many radiologists will not be so familiar with. So again, this is something to talk to your radiologist about, you know, saying how are we going to manage this recommendation if a patient comes in to our department. And then we recommended that the scan should be transferred to the regional center and be read centrally. And again, this is something that is proving quite challenging, and there is some there are some logistic issues in the radiology community about this, which I can discuss more in the questions people are interested. So that sort of sketched out really the issues relating to hyperacute treatment. So I'm going to move forward back now in the slides. But, you know, this is not really the only emergency treatment for childhood stroke. And I would urge you when you're assessing these children to think about other emergency treatments. I'm not really going to say much about thrombectomy. I can discuss this in the questions, but I would particularly urge you to be vigilant to patients who might benefit from decompressive craniectomy. And really, I think any child who has a drop in conscious level, any drop in conscious level, so unless they're GCS 15, I think that child needs transferred to a regional center and a neurosurgeon needs to be involved early, because this is potentially life-saving. In sickle cell disease, as I said, acute neurology is considered an emergency. The recommendation is to exchange the patient without waiting on the scan. It's important to maintain isovolemia, as these patients with cerebrovascular disease may not tolerate volume shifts. We would not recommend aspirin routinely in sickle cell disease. And thrombolysis or antithrombotics are not routinely given, but may have a role in selected cases. But that's probably something that needs to be discussed on a case-by-case basis. So what we're trying to move towards is recommending that all pediatric neurovascular disorders, so stroke is only one of them, is managed within a regional MDT, and the composition of this is likely to vary depending on what expertise is available. May involve adult stroke teams, for instance, adult neurologists, a variety of radiologists, and really we're trying to encourage regional teams to work with their referring general units to set up local pathways and protocols. I think we're really trying to encourage people to be proactive so that there isn't a sudden crisis when there's a sick child and no one knows, you know, what to do. And also I think, and we all felt on the GDG, that data collection and audit was really going to be a key element here. I think research is always going to be very challenging in this field because of the numbers, but I think actually good structured audit could be quite informative. And obviously what we're doing today is a part of an educational kind of initiative. I think there are big barriers. I think, we don't currently think of brain attacks pediatric emergency. I think the mindset needs to change. The imaging issues I've talked about, and I think acute transfer to regional centres is always challenging. I work in a centre where often we don't have beds to take patients. So I think, we need to think about how we can overcome some of these problems. And then, the lack of trial data. So I think the naysayers would say this is all, based on consensus, not evidence. But, I think the evidence will come from critical implementation of these kinds of recommendations. And then I think a lot of people are very anxious about using thrombolysis. These are not drugs that as pediatricians we commonly use, but I think that's where we need to work together really, and support each other in trying to implement these guidelines safely. And I think, what could help, I think changing our mindsets, I think forming working groups. So we have a working group at our centre that involves ourselves from tertiary centre, but also colleagues from referring paediatric units. I think we in the GDG have been trying to lobby stakeholder groups such as the British Paediatric Neurology Association to try and help with implementation. And I think this concept of having a toolbox is quite a useful one. So rather than reinventing the wheel, I think it would be useful to share expertise and experience on how we can overcome problems. I think having the regional MDTs will generate local champions, so people who take responsibility for actually drawing up these guidelines. I think the adult stroke physicians are actually way ahead and are very keen to try and help us, and we should try and harness that. And then, as I said, audit data, I won't go over that again. Okay, so I'm not going to say any more really about acute care. I can cover other aspects in the questions. I'm just going to move on now to talk about habilitation and rehabilitation. And, I would really encourage you to draw this document to the attention of colleagues in the MDT, so particularly therapy and nursing professionals, because the recommendations are really applicable to any acquired brain injury in childhood. And as many of you will know, there's really scant guidance on this area. I think that one principle is that the WHO ICF, so International Classification of Functioning, is the framework used in this section of the documentation. So rather than the the old impairment, disability, handicap framework, the ICF talks about activity limitation, participation, etc. And this is still terminology that is a bit clunky for maybe the old ones of us who are used to the old framework, but this is very much the model now that is internationally accepted. And essentially the key recommendations are early involvement of the MDT. So so this is in the assessment of the child with an acute stroke. So within 72 hours, with weekly reviews. And actually this was one of the key elements that transformed survival in adult stroke. So preventing patients from dying from aspiration and deep venous thrombosis was actually what really had a big impact on survival in adult stroke. And then early community liaison. And so, as many of you, as I suppose all of us will be aware, really, most children with a stroke will be managed for a short time as in an inpatient setting, and then will move out into the community, who will really take on the bulk of their longer term care. And I think it's helpful to perhaps work or alert colleagues in the community who maybe are more used to working with children with cerebral palsy, so congenital brain insult, what to expect in the context of acquired brain insult. We would very much advocate for key worker or key contact within the MDT for the family, to try and pull things together, avoid duplication, someone the family can go to with questions. And these are points that came up from the families, so particularly working in partnership with families. And I think any of us who've done rehab interventions would have seen that actually the goals for rehabilitation need to be set by the young person, not really by the therapist or the parents. And the goals that seem relatively unimportant to us may actually be things that make the biggest difference for them day-to-day activity. I think providing choice is very important, trying to consider the rehabilitation in the context of normal play and school as well. And then really thinking about the communication and how that communication will work, whether it's going to be written updates, a meeting, etc. But I think it's really important to keep the child and family at the center of the whole rehabilitation process, which is something unlike acute care that goes on for months and years. I won't go through the specific areas in a lot of detail, only from the motor domain, just to say that it's obviously important to think about not only the neurological framework, but the developmental framework. And the goal is always to maximize function rather than, say, cosmesis. I think the other important point is that the time since stroke shouldn't be a barrier to consider intensive training. And I think this is something that is quite empowering for families, where perhaps they've been discharged from therapy service as the child hits sort of growth spurt, they become functionally more incapacitated, and it hopefully will empower them to try and advocate for some more intensive therapy input. And then there are also some principles about the rehabilitation approach. Rather than prescribing specific programs, the guideline talks a lot about principles, which I think is quite helpful. Cognition is something that is often affected by childhood stroke in perhaps a rather more subtle way than in adults. And I think there are some quite helpful recommendations really about the interface with education and what could be done in the context of resource poor psychology services that might be helpful to refer to. And then, there is a lot about the needs of the family and young person. And really, this sort of section is a lot about involving the family in terms of planning and delivering rehabilitation interventions. There is a section on longer term care, transfer and transition. And this is something that many families are very fearful of. And I think the document provides a framework for thinking about how the transition may move not only in terms of health, but education and social services. There is quite a helpful flow chart, which this is really aimed at parents, trying to help them think through what might be happening at different phases of the child's journey, who might be involved in helping them, and what the sort of standard of care would be. And I think documents like this are quite empowering for parents. Certainly the sort of pathway was developed with the input of our parent members. Again, you can access this through the RCPCH website. I think important sort of principles that came up are in terms of continuity, having good communication, good handover, having communication between the different services. And this is where I think a key worker can help. Having flexibility, so not just rigidly sticking to a program, but really thinking about what that child and family needs. And I think utilization of charities sector support is really important. And the Stroke Association has really taken on childhood stroke in a big way. So if you go to this website here, there are many resources. There is a little info video for children. There's a family handbook. There's questions that families could ask when the child goes back to school, and they actually have a childhood stroke support worker who is somebody who can help signpost families, support families. So I would definitely direct families to that. Okay, I'm going to wind up now. I'm sorry about the slight glitch in the middle, but hopefully I've just covered some of the acute care aspects relating and rehab principles relating to childhood stroke. But it's just to say that this guideline also covers brain hemorrhage in children, and that the rehab recommendations are more generalizable across other acquired brain injury. And I hope that, you know, I've kind of got across the message that I understand these are challenging recommendations and will require working together. And I hope that initiatives like this will really encourage and help with implementation. Okay, I'm going to stop there now, and I think we can take questions.
Thank you very much, Dr. Ganesan. That was really detailed and really useful. We have some questions that have come in already while the presentation has been going on. Just to say that if anybody else has questions, please do submit them through the questions function of your webinar, and we will take them during the 25 minutes that we've got left. So the first question that's come in is in relation to management of subarachnoid hemorrhage, measures to stabilise blood pressure. Are there any recommended medications?
Yeah, I mean, I'm not sure whether you're specifically talking about management of hypertension in the context of subarachnoid hemorrhage. Is that? Oh, no. Okay. So sorry, I'm not quite sure how this works. So yes, there are recommendations about management of subarachnoid hemorrhage. And actually, the model is very much like management of subarachnoid hemorrhage in adults. So, you know, basic management would be supportive, including neurosurgical intervention if that was indicated. I'm guessing that your question probably refers to use of nimodipine. So we did recommend that nimodipine was used in the management of children with subarachnoid hemorrhage. But in that context, it's really being used for vasospasm rather than for management of hypertension, because as you know, most subarachnoid hemorrhage is aneurysmal rather than secondary to hypertension. So if you look in the document, there's actually a dosing regime for nimodipine for pediatric subarachnoid hemorrhage.
Thank you. Our next question is there any plan for developing guidelines for neonatal stroke?
Yeah, I mean, that's a good question. And actually, I don't know is the answer. But, the scope of the document was put out to stakeholders, and that wasn't something that came across in this iteration. The college, now that the document is owned by the college, there is a very a clear process in terms of updating and revision, and I would assume that the scope would be put out possibly for consultation again. I think that if people feel strongly about that, they should write into the college, because as with the brain hemorrhage, well, I was personally quite reluctant to go there because it was a lot of work, but it was clear that that's what people wanted and that's what people would find useful. So the answer is no, not at the moment, but there would be opportunity to request that.
Thank you. Another question that's come in is, what are the prognostic criteria for stroke in general?
Oh my Lord, right. That's probably like a very broad topic. What can I say that's meaningful? I guess it depends what you mean by prognosis. I'm guessing you mean sort of neurological prognosis rather than prognosis in terms of recurrence, although I could cover that if people were interested. I think that the prognosis would depend really on several things. I think brain ischemia and brain hemorrhage and venous so arterial and venous ischemia all have very different profiles in terms of eventual outcome. I think it is very difficult to draw, to make generalizations. What I'm going to talk about brain ischemia, since that's what we focused this webinar on. So I think that age is an important prognostic factor. So in my view, older age is an adverse prognostic factor. Patients who are unconscious at presentation would generally have a worse outcome, but that probably just reflects the fact they've had a much bigger stroke. I think that half of children who have an ischemic stroke will have some comorbidity, so they may have cardiac disease, sickle cell disease, etc. So that would also influence the outcome. What I would say is that the concept that the child's brain is plastic and therefore can tolerate stroke and recover is actually a fallacy. I would say that the child's brain recovers differently from the adult brain. So most children who have a stroke will walk out of hospital, they will go to a normal school, but their potential to achieve and engage in employment, social activity will be significantly different. I think the other thing I would say is that the cognitive and emotional sequelae of childhood stroke are significantly underestimated, and in my experience can be, crippling in children who actually have very minimal motor deficit. I think beyond that, I'm not sure I can sort of say a lot more. I think the prognosis really needs to be tailored according to the child factors and the lesional factors really in individual cases.
Thank you. We have a question which may not be complete, so may need a little interpretation. The question is, complications while giving what needs monitoring of TPA treatment?
Yeah, okay, thank you. That's a really good question. So, sorry, I hope the TPA section kind of came through clearly, but what we're proposing is that, the child with acute weakness comes in, has a brain scan within an hour, so probably a CT, CTA, and that you all conference in via this retrieval sort of network teleconferencing system, make a decision whether or not to treat, but really the treatment will need to be given in the district general hospital. Now, my own feeling is that parents should receive information and be asked for consent, because this is an off-label use of TPA. So that's one thing. And one of the resources we're working towards in my own trust, and once we have these resources, we would envisage making them freely available. So one of the resources we're working towards is like a information sheet for parents, and a sort of, which would include the envisaged risks and benefits. The TPA will be is given as a bolus and then a continuous infusion. The risks are obviously bleeding, and those risks shouldn't be underestimated. So we are dealing with an immature coagulation system. I think the key issue to look out for is bleeding, not only bleeding in the head, but systemic bleeding. I think it is very difficult to quantify that in the context of giving TPA for a clot in the head. Because there is no data. What should you look out for? Well, obviously vital signs, pulse, blood pressure, etc. Any visible signs of bleeding, any deterioration, so particularly worsening neurological deficit or a depression in the conscious level. One thing I should say is that I was recently involved in a case where a patient was sent to my center from another tertiary neuroscience center because they were under the misapprehension that TPA for arterial ischemic stroke had to be given in a center with neurosurgical cover. In fact, that's not the case, and that's not the case in adults either. So, just to be clear about that.
Thank you. We have a question. Do you think there is a role or necessity for establishing hyperacute stroke units similar to adult units?
Yeah, I mean, basically, as I said, I think the average DGH will not even see one child who's eligible for hyperacute treatment a year. So, I mean, it's just not going to work out, is it really? And I think that, I think a really good model would be for us to work in partnership with the adult units. I mean, in the adult hyperacute units, what works really well is that the patient hits the door and there's a seamless pathway to imaging, to drawing up the infusion, to giving the treatment. But, what we need to input into that is actually assessing the child, and making them aware that the spectrum of potential diagnoses is much wider. So in an adult, for instance, a patient with an acute hemiplegia who has a normal CT scan will be given TPA, whereas a child with a normal CT scan would only be given TPA if they also have occlusive disease in a large artery. And that's a really fundamental difference in approach. So, I don't think really it is sensible or feasible to establish hyperacute units for children, but I think we could usefully work together with the adult units.
Thank you. So specific question, when would you use aspirin in the management of stroke due to sickle cell disease? Is there a rule?
Okay, so I should have said, and it's always really difficult to know what to pick out when you do these kind of highlights talks, but I should have said that the default intervention for children with arterial ischemic stroke is aspirin. I mean, I've talked about hyperacute therapy, but you know, for the majority of children, they will not meet criteria and they will be put on aspirin. So when would I use aspirin? I suppose I would not be using aspirin to manage sickle cell related stroke, but I have seen a number of children, I would say approaching 10 or a dozen children now with sickle cell disease who've had arterial dissection, so a tear in the artery in the neck, and I would treat them with aspirin as I would in you know, another child. And I think this is a really important lesson, that just because they've got sickle cell doesn't mean that they can't have some other condition. I have sometimes used aspirin in children with sickle cell who have been refractory to very aggressive exchange transfusion as a bit of a last ditch belt and braces approach. I can't advocate that in any evidence-based way, but I think that the main indication would be if they have another diagnosis that would mandate antiplatelet therapy.
Thank you. So the question is, in absence of true child development teams and going on to only virtual teams, often across different NHS trusts, with no real working together and absence of a key person in children with neurodisability, how is this function envisaged as being coordinated?
Yeah, I mean, I don't know really. I think we're all working, you know, in situations of stripped back resources. I think that as I said, for any aspect of this guidance, there's not going to be a one-size-fits-all model. I think people often feel anxious or cross when these kinds of documents are published because they think, how can I possibly, deliver this? You know, a good example, for instance, is in a school where maybe there's a recommendation to do a cognitive assessment, and they have one educational psychology session for the whole school for the whole term. You know, how is this realistic? But in issuing guidance like this, we hope it'll empower clinicians really to advocate for resources. I think really the key thing is to be imaginative, really, and to try and think about how the child's needs can be met. That may not necessarily be through healthcare. It may be through social care or through education. I mean, I don't think I have an easy answer, obviously, and also obviously I'm a specialist working in acute sector, but you know, many colleagues from therapy sector were involved in drawing up the recommendations.
Thank you. Possibly related question is, how would you counsel a family regarding acute thrombosis?
Regarding acute thrombosis.
The question is acute thrombosis. It may be acute thrombolysis.
Okay. So the question is about thrombolysis in under twos. I mean, yeah. So you know, as I said, the guidance is to consider. Yeah, I'm not going to say the word now because I always get it wrong, but basically it's a less strong recommendation in 2 to 8 year olds and a stronger recommendation in over 8s. The question is about under 2s. I mean, I really think that there is no evidence either of safety or efficacy at any age, and I think that the under 2s are particularly vulnerable because the coagulation system is particularly unstable, sort of developing and evolving, and you know, I would not be pushing under 2 year old for hyperacute therapy. Yeah, I mean, I think, you know, the cutoff has to be drawn somewhere. And, you know, as I said, the criteria we used were ones that have been through a very rigorous US ethics committee, and 2 was felt to be the bottom age, so I would stick with that. And you know, I would really try and encourage people to use the guideline as a guideline and not as something set in stone. So you know, if you have reasons that you think a particular patient might benefit that is deviating from guideline, I mean, as clinicians we're able to, you know, practice in that way, and if you don't wish to follow the recommendation, if there are clinical reasons, you know, again, as clinicians we obviously have to exercise judgment.
Thank you. What advice would you give to encourage paediatric nurses to give TPA in hospital settings where the nurses have not been trained or the majority have never used it before?
Yeah, that's a really good question. I think that, so, I suppose one of the things I'm hoping that events like this will generate is actually some awareness amongst all kinds of teams. So general pediatric teams, specialist teams, and community teams about actually what does this mean on the ground. So I would encourage, if you're a pediatrician working in a general unit, I would encourage you to have that discussion with your nursing team, about, say, what level of nurse would be needed to administer the infusion, to maybe get some in-service training for the nursing staff. The thing is, when it happens, it will happen as an emergency and everybody will be in a flat panic. So it's good to have maybe thought about it and thought about what training could be done in-house to upskill people, on the ground. Yeah.
Going back to the question around aspirin, I have a question. When would you consider giving aspirin or warfarin in terms of when would you consider giving aspirin or warfarin long-term for prevention of recurrence?
Yeah, okay, thanks very much for that question. So as I said, the default option for most children, so most children won't be a candidate for hyperacute therapy, and the default option would be to put them on aspirin unless they've got sickle cell disease. But anticoagulation now pretty much has a very, very minor role in the management of acute ischemic stroke in children. So arterial ischemic stroke, I'm talking about, not venous. The only situation really is where in some cases of cardiac embolism, and in that case, in that situation, I think there needs to be a discussion between the treating neurologist and cardiologist about whether you think what level of antithrombotic treatment you want to initiate. So whether you think aspirin will hold the patient, or whether you think you need to escalate to heparin or warfarin. And then pretty much in the longer term, the management will really depend on what the cause is, what the risk factors you identify. So pretty much over 80% of children having arterial ischemic stroke will have some abnormality of the brain circulation, and really the morphology of that cerebrovascular abnormality will really determine the subsequent management. We haven't in the guideline made a recommendation about longer term duration of therapy, because it's not straightforward, and probably that is something I think the regional teams will be advising about. But my own practice is generally if someone's got an arteriopathy, I would treat them for a minimum of 5 years with antiplatelet therapy. If they have moya, I would refer them for surgical evaluation. If they have progressive arterial disease, I would evaluate them for vasculitis and consider immunosuppression. If they have a normal brain and neck circulation, I would probably stop antiplatelet therapy after a year. But that's a personal view.
Thank you. How is it proposed that each DGH set up a stroke service with such low incidence?
Yeah, I mean, I suppose I don't have the answer really, but I think that this is why I think sharing resources is really important. I think that thinking about it ahead of time is really important. I mean, actually, if you think about the numbers of children who come in with, if you talk about brain attack more generally, acute focal neurology, I don't think that is a rare presentation in children. I think what is difficult is moving from that, which is dealt with now as a relatively cold presentation, to moving that towards a kind of more emergency assessment and management type of scenario. I mean, I don't have the answers, but I think what we have tried to do is really define what we think the standard of care should be in the current, given the current evidence base, and then try and work together really to achieve it.
Thank you. This next one is more of a recommendation than a question. One of our audience members has suggested a website, hemihelp.org.uk, is useful.
Yeah, I mean, HemiHelp is a great organisation, and they're obviously an organisation that helps children with hemiplegia, and I totally agree, it's very useful, and they have a lot of written resources as well, and one of the parents who's involved in HemiHelp has published a book with Dr. Charlie Fairhurst about helping children with hemiplegia that I think is a very useful practical resource for families.
And then a final question, what are the commonest etiologies for childhood stroke in your experience in the UK, and also the most relevant immediate blood investigations?
Okay, that could be another webinar, but so just some headlines really. So as I said, half of children who have an arterial ischemic stroke will have another medical condition. So I've covered some of the sickle cell disease, cardiac disease, malignancy, etc., genetic conditions, although those are maybe less common other than sickle cell disease. Over 80% of children with an arterial ischemic stroke will have an abnormality of the brain or neck circulation, which is usually non-atheromatous disease of differing types. So this entity called focal cerebral arteriopathy, where they get a focal narrowing of an intracranial artery, or dissection, or moya. So that's by far the commonest sort of category. Cardiac embolism, I guess, out of the blue, so without the child having had known cardiac disease, is actually quite unusual, but obviously important to exclude. And then there's a whole ragbag of other things. I think in terms of investigations, I'm actually going to stray a bit beyond the question. Think about what are the tests that you really need to do when you see a child in acute stroke. So I think the priority is to make the diagnosis, so get a brain scan, and then I think really you want to look at the blood vessel, so an MRA from the aortic arch to the circle of Willis, looking for the arterial diseases I've mentioned, which will really determine your subsequent management. And then the other investigation I would prioritize is an echocardiogram, because although previously undiagnosed cardiac disease is rare, it does happen, and it will fundamentally alter management. So I'm thinking about things like endocarditis, for instance, specifically. In terms of blood investigations, I would tend to measure simple things like a blood count, make sure the patient's not anemic, because that's something you can easily optimize to improve oxygen carriage to the brain, and then just the general evaluation. I think one of the other recommendations that we put out for Delphi consensus was about the need to do a thrombophilia screen. And actually, we could not really achieve a consensus on this. And I think this reflects clinical practice, where people feel passionately one way or the other. I mean, diagnosing thrombophilia doesn't actually alter management of childhood stroke. It's very expensive investigation. It has implications for other family members. But people are just wedded to this. So I think that it becomes a matter of personal choice, personal practice, and that's how we've worded it in the guideline document.
Thank you. And a final follow-up question, which you may have responded to already, is which are the congenital heart diseases that increase the risk of stroke?
Yeah, I mean, really anything that where there's a right to left shunt, so particularly, like a ASD, for instance. PFO is not proven to be, so PFO, patent foramen ovale, ASD is atrial septal defect. So PFO is not proven to be etiologically linked to childhood stroke. And I would really counsel you not to let a cardiologist close a PFO in a child without getting a neurological opinion as to whether or not it's relevant. And then the other situation is really in heart failure, so cardiomyopathy or heart failure for other reasons where the heart is hypocontractile, and clots might form, and then endocarditis I've talked about.
Thank you. So that concludes our webinar on stroke in childhood. A huge thank you to Dr. Ganesan for her presentation, also for fielding all those questions at the end. And also a very big thank you to those of you who've been able to dial in and listen to this webinar. The webinar has been recorded and will be available on the RCPCH Compass website in approximately a week's time. If you go to the main RCPCH website and enter Compass as your search term, it will direct you to that separate site, and you'll be able to access this recording in the archive section. We do value your feedback, so please do complete the feedback short survey that we'll be sending you after the session today. Yourself or through the Compass feedback survey that you can access through the links that you can see on your screen. Thank you very much for your time today.